when the connecting team got in touch with me, I tried really hard to convince them that I should not be the one to give this keynote. And then I was like, okay, if I'm giving the keynote, do you really want me to be on the panel as well? And they were insistent and very gracious. So here I am. And before I start, because I don't know the access needs in the room, and this is something I do everywhere I go, I give a visual description of myself because for those with visual impairment, they may not be able to take in the same visual cues that many of you in this room do about appearance, body language, etc. So, keeping that in mind, I am wearing a shirt which is a purple maroon color, I guess, and jeans. I have short, mostly black hair. There's some white streaks in there. And yeah, I'm pretty fair for a brown skinned person. So that's visual information about me. First, I wanted to say thank you to everyone for bringing us here together, and a big thank you to the practitioners, researchers, funders, policymakers, and community leaders in this room, and those who are beyond it as well, but who work every day to make people feel safer and more supported. I think everyone in this room does that. So here's a big thanks for that. Again, to get this out of the way, this is a content warning because I will be talking about potentially distressing things. But of course, the organizers have their own phone line that you can reach out to, and maybe there are people in this room that you can speak to if you do feel distress. A bit of introduction. MHI is a Mariwala Health Initiative, is a grant-making, advocacy and capacity-building organization. We currently have 100 partner organizations in 24 states in the country. And I won't spend too much time talking about my organization, but in terms of suicide prevention, in 2021, we launched our report, which was a multi-stakeholder consultation-based report called Changing the Narrative. We also launched the Alliance for Suicide Prevention. We've done multiple consultations and roundtables with different stakeholders, including political representatives. And I believe that Sukriti from ETI has either spoken to you already, but she was one of the partners that we relied on to get the release of the National Suicide Prevention Strategy to happen. So that's the kind of advocacy work that we do. We also did some work around G20 and getting mental health and suicide prevention in the G20 brief. And that's, now all the formalities out of the way. So we'll just get to the main topic now. And I'm not going to share any numbers on this issue, simply because there are many people here who know this much better than I do. And also because I believe that everyone who's in this room doesn't need any convincing that suicide is a serious public health issue facing India today. So instead, I'm going to speak about another related problem. Today, at the core of suicide prevention strategies in India and in many other places, lies the presumption that death by suicide is a problem that can be dealt with by providing individuals one-on-one help, such as access to counselors and helplines. And these interventions are really important, there's no doubt. But we are in danger of missing the bigger picture if we focus only on these. And let's just see reportage in newspapers around suicide. It typically, yes, does involve discussion around helplines, crisis lines, as well as expert opinions from psychiatrists or psychologists usually. And again, the problem with this type of reporting is that there tends to be a dangerous oversimplification that narrowly focuses on the individual, maybe on one factor even, mental illness, and at only one point in that individual's trajectory. That is acute crisis. To illustrate, suicide helplines tend to be designed for those who may be in acute distress or maybe those who are at risk of attempting suicide. And these are critical. But they are not the panacea for suicide prevention. And the same applies if we just look at therapy or psychiatry as a one-size-fits-all approach to suicide prevention, especially when services are decontextualized and solely expert-led. And that's simply because suicide is a complex problem. And it's very hard, especially in our contexts, to separate it cleanly from social, economic, cultural, political, and even historical contexts. I think a lot of the individual focused approaches often view suicide through a very narrow lens of personal failure or mental health breakdown. But of course, in LMICs, where over 70% of global suicide deaths occur, less than 50% of suicides can be cleanly attributed to, say, depression or mental illness. And we do provide, helplines do provide support, right, in moments of crisis. But they rarely are able to address the structural drivers of distress. Poverty, discrimination, exclusion, and these are things that affect entire communities. Don't take my word for it. NCRB data shows it, right? These are systemic challenges that are visible in that data. Suicide deaths in 2022, nearly 1/3 were daily wage workers. And who are daily wage workers? People with the least social protection, most precarious incomes, and very few buffer systems. Now, these are not isolated or individual psychiatric events. These are structural patterns. And just as an example, someone called Raman Garase, he was an IIT Bombay employee, and he tended gardens there for 39 years. He was paid a daily wage in every day of those 39 years, at the end of which it was, I think, 739 rupees a day. And he died by suicide after a very long struggle to claim his gratuity. And his life just exemplifies how bureaucratic exclusion, how this precarity, this lack of social protection, and workplace humiliation led him to such despair. It's a very similar story, even though the solutions are not going to be same, for farmers in Maharashtra, right? Between January and April 2025 alone, 869 farmers have died by suicide. And this is in a space where we are undercounting suicides, where women farmers are not counted as farmers. And so the issue is, when people see suicide as the only way out of an inescapable economic trap, it's not a symptom of individual pathology. It's a failure of policy, right? Another such systems failure is in youth suicide. And suicide is the leading cause of death for young Indians in many age brackets. And of course, if you look at the media, what is likely to come up in your head? Quota, exam, academic pressure, and these are all very real, but they're only part of the story. Right? Again, NCRB data shows that personal and social factors, family problems, marriage-related issues, romantic conflicts, accounted for 45% of youth suicide deaths. And these gender dynamics matter very deeply. Because contrary to global trends, young women's suicide in India is a big problem. Socioeconomic vulnerability combined with control over sexuality, limited mobility, lack of agency, threat of early marriage, threat of pregnancy, familial pressure, harassment, violence, all contribute to a very uniquely gendered pathway to suicide. And I'm sharing these examples because they really underscore the need to move beyond individualized solutions to those that address the deeper systemic roots. Because the simple fact of the matter is that suicide prevention should begin long before a crisis. It should begin in the everyday realities of people's lives, in their access to safety, dignity, and belonging. And here, I'm going to say that the organizing team had very kindly offered that we should speak about what connects us to this work, personal reasons, impetus to do this work, etc. And when I read it, I thought to myself, oh, there's nothing in my life like that. There's no personal. And then I said, okay, wait. I took a pause. And of course, I was surprised by how many personal instances I myself had. So the first time I lost someone to suicide was as a young queer person who had a slightly older, well, at that time I thought he was old, 30-year-old, gay male friend, George. I've changed his name. He was a safe space for me. When I felt alone, when I felt isolated, when I wasn't unsure. Someone who I leaned on, but also did regular things with, like exchanging music, listening to the music that he listened to, and vice versa. Hung out in his house. We shared our writing together. The last time I met him was at a queer Christmas party he hosted at his home, where I met other queer people. So much warmth, joy, cheer, everything a party should be. And 3 days later, he was gone, struggling with the rejection that he had to live with from his family. And at that time, as a young queer person, apart from, feeling the deep loss, I remember very clearly the sense of bleakness and question marks over what Paul's death meant for my future and what it meant for the future of queer trans people. If Paul couldn't make it, then how many of us were going to make it, right? And so a couple of years later, actually, when I was part of a queer trans feminist collective, I advocated for a phone line there. And we got the phone line, I was part of it. I got some basic training. I used to handle the phone line and answer it. Callers in distress, callers facing violence from family, in homes, in schools, in workplaces. And yes, of course, callers who wanted to self-harm, had self-harm, or had suicidal ideations. In one such instance, there was a repeat caller, someone the same age as me, actually. And again, I'm going to change her name, but Mona, who sent text messages during helpline hours about her intentions to self-harm and about her suicidal ideation. Why? She was a young lesbian woman whose family was violent, who she had to move away from, move to Bombay, but whose roommates in Bombay were also discriminatory and violent, whose landlord took her side. She kept on facing discrimination at work, in college, and she was tired of it all. Here was someone who had repeat calls with me as a peer support community member, someone who had therapy, access to therapy, someone who had access to medication. And yet we were in this situation. So I tried calling her phone kept on ringing, and then it was off. We couldn't go to the police to figure out where she was. 2 reasons: criminalization of homosexuality and criminalization of suicide attempt, right? However, we did come together as a community and started making calls. We reached out to one such community member who worked at a phone company, who I won't name, and they helped us track her phone. We fanned out all over the city. For the next 6 hours, we were searching in various locations, including doing things like convincing security guards in random buildings to let us in so that we could knock on certain apartment doors, etc. Finally, one group did find her and got her emergency medical attention that saved her life. We all came together post that for legal support, medical support, and to provide her a safe space to recuperate after she was discharged. Now, all of this was quite challenging, by the way, especially in a medical setting because none of us were family. She had all the resources. She was also calling. So, what gives? What happened? And this is why I say crisis services, helplines, psychiatrists, emergency care, it does save lives. It saved her life. When someone is in acute distress, immediate support can be the difference between life and death. I saw it. The problem is, if we rely solely on this as the central answer, as if phone lines or hotlines fix the underlying reasons that people are calling, then it's a dangerous territory to be in, right? It cannot just be emergency interventions. These are vital, yes, but only one part of the picture. So I shared this story because, yes, as a field, maybe mental health focuses on psychiatric services, clinics, helplines. But part of, I think, shouldering the responsibility for this outlook lies to people like me, funders, who feel a pressure to show results, who prefer programs that yield quick indicators. Number of helpline calls, number of sessions delivered, number of lives saved. These are measurable, but they tell us very little about whether a program is changing the conditions that produced that distress, that produced that despair. Right? So, yes, we need to make some changes in the way that we do mental health. And part of that responsibility really is with funders. Because funders need to realize that, yes, short-term projects are very clearly useful, but they cannot substitute for long-term investments in social protection, housing, labor rights, educational inclusion, legal recourse, gender justice, and social justice. Suicide prevention requires slow work, community trust building, peer networks, legal advocacy, entitlements. It's hardest to measure, yes, and it is very easy to ignore, but it is vital. And that's why today I invite you all to widen the lens, to look at suicide prevention as intersectional, and why shifting power and resources is critical for that to happen, and why we need ecosystems of care, not isolated interventions. And part of having ecosystems of care is policy measures and institutions that are held accountable to do this. So in that sense, my hope is that we all can engage with suicide prevention as, yes, intersectional, but also intersectoral, and a responsibility, a collective project that belongs to all of us, because suicide does not emerge in a vacuum. And the distress that I was talking about in those personal examples, it emerged within social, political, cultural, and economic structures. And these are the structures that shape who has access to care, who is harmed, and who is ignored. Now, if you take a look at our report, I won't spend much time on that. It's in English and in Hindi. It details how precarity, how discrimination, and how exclusion accumulate over time. Caste-based discrimination, gendered violence, queer phobia, lack of disability access, food and livelihood insecurity, displacement, climate crises, and conflict. These are not conditions that just worsen distress. They shape what options are available to people when they seek help, and whether help is even available at all. And this is why we cannot meaningfully prevent suicide if we treat it as an outcome of only individual mental illness. I think the perspective shift that I really want to underline today is that in many cases, we must understand suicide as an outcome of systems, an outcome of systems failures, systems that produce instability, invisibilize suffering, or actively harm certain communities. And what are some of the questions that we must ask? We emphasize helplines without asking what conditions make people call in the first place. We build suicide prevention messaging that tells people to reach out, but does nothing to fix the institutions or environments producing despair. We pour resources into clinical services while underfunding housing, disability support, education reform, crisis services, violence interventions, and community collectives. Funders, there's absolutely nothing wrong with clinics. There's nothing wrong with therapy. There's nothing wrong with funding those. But alongside funding those, there's some more funding you need to do. Now, even as we work towards suicide prevention, and if we take a longer term approach, acknowledging systemic discrimination is crucial. And, sure, if I say there is discrimination, I'm moving the focus from individual choice to the role of structures and systems. But is the acknowledgement enough? Is it important enough when we are critically looking at prevention methodology? If we don't do this carefully, we might end up silencing the voices of those who live with suicidal ideation, right? And so there's an ethical imperative there. We need to be careful, yes, about acknowledging discrimination, but also as thoughtful about not silencing those who are in distress. How do we steer away from perpetuating oppression towards those in crisis? For example, the focus on methods, certain, I think, really well-known methods, such as reducing access to means, willfully overlooks structural violence. Now, different types of fans, national helplines are not enough because we will keep on losing people like Pranchu, who was a young queer person who lost their life to online bullying, Dr. Payal Tadvi, Rohit Vemula, both 26-year-olds, or a 16-year-old called Kunal, who was gay and dyslexic, right? We don't know what their voice said. Well, we know what Rohit said, but the others. And the reason I'm saying that we need to look at this carefully is because my other argument is that it is unethical to offer only the dominant approaches to suicide prevention. The roots of suicide prevention work, reducing access to means, those have a deeply colonial history. In the prevention of suicide of those who were captive aboard slave ships from Africa, going to Europe and the USA. Enslaved men and women killed themselves for many reasons because they were unable to cope with the long and traumatic journey. They were beaten, raped. So dying by suicide for them was also an act of rebellion. The crews of the slave ships, by the way, were always anxious to prevent death by suicide because it ate into profits. Thus started the idea of reducing access to means with nets around the ships and force feeding slaves. So if we are to keep history in mind, we need to be very careful about decentering the coloniality of dominant approaches in suicide prevention. So suicide is not only a clinical problem, it is a development, social justice, and rights problem. And the dominant approaches have a colonial history, and so they are necessary, but also insufficient because they can be dangerously decontextualized. And third, especially for the funders in the room, we must shift power and resources to community-led, intersectional, intersectoral, and long-term work. And we must change how we think and act when it comes to suicide prevention. For this, I'm going to talk about a failure that we had in our work at MHI. We were approached by a premier organization, a premier educational institution of this country, after a couple of students died by suicide. And we were asked to train their counseling staff. And we said, fine, great, this is amazing. This is, one of the most well-known institutions in this country. We are glad they're taking this step. We started training the counselors, and there was hardly an interest. They did not want to learn about caste affirmative work. They did not want to learn about queer affirmative work. And part of the problem was there was no buy-in for the management. Management didn't care. The counselors weren't interested in it. They weren't keen on it, and it showed. Now, I'm not blaming the counselors at all. In fact, you should resist the urge to blame the counselors in these types of scenarios, because they're just a much smaller part of the bigger machinery. Unless the management changed how students were treated, unless the management changed and had zero tolerance policies for bullying, for anti-caste ragging, clauses for protection, nothing was going to change. So obviously the counselors knew what their limitations were. So it's very important for us to look at the structure again. The fight is collective and it is structural. Instead, in recent events, again, I want to say this, it was recently Loss of Suicide Survivors Day, and two mothers showed us the way forward. Abida Salim Tadvi and Radhika Vemula, the mothers of Rohit and Payal, fought a case in the Supreme Court. And their advocate said that these mothers filed the case not for themselves, but to prevent further student suicides. And the case was on caste-based discrimination on campuses and how it dealt harm and how institutions failed to respond. And this survivor-led fight has shaped a push for structural accountability. So the Supreme Court order, their latest order, has emerged from this struggle, and it has highlighted 10 areas that the UGC must strengthen. So to ban discriminatory practices, no segregation in classrooms, hostels, etc. by caste, very strong grievance systems to complain, and these committees who do listen to the grievances must have scheduled caste, scheduled tribe, OBC representation, protection for complainants, and of course counselors trained in caste trauma and institutional discrimination. Now, if I have to look at an example of policy, this does it right. It engages in multiple pathways to prevent structural harm. Policies on campus, policies in systems, and learning and adaptation, contextualization within formal mental health structures. And this is really important because on campuses, caste shows up as exclusion, biased evaluations, delayed scholarships, segregation, administrative inaction. And these forms of discrimination directly impact student safety. And the reason why I bring in formal mental health structures and the Supreme Court directive to train counselors is because when counselors are not trained in caste realities, they often minimize caste trauma, treat institutional violence as personal distress, pathologize the student, and overlook ongoing harm, right? So I shared our failure and I shared what has happened now in policy, just to say that these are solutions that come from a space of community organizing. And so when we are looking for ways to do suicide prevention better, we need to look at community-based care and organizing because it involves individuals from affected communities. And they have been providing support services and care for a very long time. And of course, it doesn't mean that we don't include formal mental health. That is imperative. We're not doing away with that. But it's very important to do both and to enable access to social benefits and protections. Not only does this reduce the need for costly, solely expert-led interventions, but it also reduces the cost of accessing care for individuals, both of which are very important in low-resource settings. And I'll give you an example again on this issue. In Pondicherry, which is a union territory, they have a consistently high suicide rate, especially for young folks. The government has decided to do telemental health, and they have a program on family integration. Our partner, the Trust for Youth and Child Leadership, works with marginalized youth, first-generation learners, Dalit Bahujan Adivasi learners, and they have a helpline which is staffed by professionals, a physical center, community outreach, and linkages to employment services, to education support, career guidance, and self-development. So all the pathways link to suicide prevention. Counseling services are needed, they're a must, yes, but the other things are as important. And I wanted to highlight this program for you because they looked at the need for both intersectionality in intervention design, caste, education background, but also intersectorality, linking to other services. Now, both the examples of the two mothers who fought in the Supreme Court and TYCL in Pondicherry illustrate that local and contextual knowledge and empowerment are key to addressing multiple factors that lead to suicide and its trajectories, whether it's prevention, intervention, crisis response, or postvention. And if we are to undertake comprehensive suicide prevention efforts, we need to look beyond acute crisis, but also beyond biomedical expert-led approaches, and instead to community-led work that is contextual and based on lived experience. Now I'm going to speak to the funders in the room. We need to do things differently. No short-term measurable outcomes. Yes, I'm sure that we all have comfort with funding helplines, crisis response apps, very nicely, neatly detailed clinical projects. But we need to start funding the slower, relational, community-rooted work. Because we cannot fund suicide prevention that happens only downstream. If you fund interventions at the point of collapse, instead of investing upstream, where discrimination, violence, deprivation are quietly shaping people's lives, we have a problem. So what does this mean? Funding collectives, organizations, community-led work, led by those with lived experience, trusting communities as knowledge producers, not just as beneficiaries, supporting interdisciplinary approaches that combine legal aid, social protection, mental health care, and community strengthening. And here's one such example. MHI's partner, Thar Mahila Sangathan, works in the Thar Desert. It's a remote region, it's really harsh climate, it's a border district, it has a label of backward district, and about 20% of the population is marginalized castes and tribal communities. This community has faced a very high number of well deaths among women since 2017. The reasons found have been discrimination against intercaste relationships, domestic violence, early marriage, dowry, debt, and drought. Now, the government response has been means restriction and a very short-lived helpline initiative. So our partner Thar Mahila Sangathan on the ground addresses patriarchal oppression of women and its manifestations, so dowry, child marriage, rape, domestic violence, uses casework as prevention, but is also doing fact-finding on the deaths of women by suicide, and action research on root causes. And we're supporting the documentation and the research of same as funders. But as funders, when you fund this, it's very important to also fund the publishing and dissemination of this knowledge creation and treat this knowledge creation as no less than the knowledge creation that comes from expert researchers, that comes from psychiatrists. So the Thar Mahila Sangathan work will be published in an international journal sooner, hopefully rather than later. And again, I want to mention that this is addressing systemic violence as prevention, moving beyond means restriction. It's a social change approach for root cause prevention, right? And so as a funder, when you look at this, what are the things that you would see? You would see supporting their knowledge creation, but also moving funding into social protection, housing, livelihood support, legal aid, supporting people whose work straddles multiple sectors, and of course, as a funder, refusing to silo mental health away from social justice. We know that distress does not happen in isolation. Our funding and our interventions cannot be isolated either. Now, in that sense, what has this taught us at MHI? I'm going to share a practice of a community-led crisis and care model. And this started actually from, the story that I shared earlier personally, where I was hanging on to that helpline. My experience taught me, and I've known from experience, that communities who have been excluded from formal systems have not waited to build support. We have created our networks of protection, whether it's shelter, food, crisis support, help with documentation, legal aid. And these forms of care are critical when there is escalation. So we conceptualize something that we call the Community Connect Fund in an effort to confront the repetition of oppressive patterns towards suicidal individuals and to build a case for visibly resourcing suicide prevention that de-emphasizes biomedical, depoliticized approaches and shifts to more expansive frameworks of care, interdependence, and social justice. And this is where I looked to queer trans collectives. I've been part of such organizing. And they've been the first point of contact and support for so many people in the community, doing untiring work and foregrounding lived experience and knowledge from the margins. And this peer support is as crucial to queer trans well-being as formal traditional mental health work. Now, from research, we know that peer and community acceptance can help in preventing suicide amongst queer trans youth. And that peer support can be life-saving and help receivers feel more in control of their lives. I just shared my own story with you, right? So with this belief, we looked to resource that very presence of community to create visibility and to create, therefore, the idea of possibilities of living as a queer trans person in a stigmatizing society. The idea that the presence of community and community building is a suicide prevention action. So what we did is we established a multi-pronged strategy, both funding and capacity building, to address suicide within queer trans communities by supporting the work of 20 queer trans collectives or organizations in smaller cities or in towns. So we gave them some funding to do whatever they were doing, just keep on doing it. We gave them another separate pot of funding purely for crisis intervention. And then we said, we're going to do some capacity building work with you, suicide prevention training that is contextualized, peer support training, and also post-vention training, right? So we've just finished year 1 of this. It's supposed to be for 3 years. And I can share some of that data with you, but these 20 organizations have used the funding for advocacy, capacity building, community building, research, human resources, setting up helplines, and community leadership. The crisis funding has also been used for medical emergency support, counseling support, housing support, food support, travel support, clothing, basic needs, education, flood relief, and legal fees. Now, for me, this is an example of an intersectional response framework to suicide prevention, to harm reduction. These forms of prevention don't look like traditional mental health services, but they're very much suicide prevention. I want to say that this is an example, at least for me, about how community-led, culturally grounded practices offer stable, everyday forms of care. The post-vention component is something that I do want to talk about because marginalized communities experience losses by suicide differently. When someone dies by suicide, it reinforces the idea of fragility of our own lives. I mean, I spoke about George's example. Even if it's someone that we don't know, and more so when well-known leaders or activists are lost. Partly because sometimes there's no one to grieve for us, or perhaps not give dignity in death, or perhaps because of disenfranchised grief. And it's not just queer trans communities. We saw that after the death of Rohit Vemula. Therefore, post-vention is also a critical intervention that we do not talk about enough. In fact, in 10 days from today, we have a memorial for a very fierce queer feminist activist who we lost 10 years ago, who did absolutely groundbreaking work. And I remember again at the time, a lot of us thinking, and I hadn't met her, but she was part of the same circles. A lot of us thought that if she couldn't make it, it raised questions about how we all could make it. And that, according to Judith Butler, a good life is one that can be considered livable and is sustained by community and social conditions, not just individual effort. Now, achieving a livable life requires addressing how social structures and political norms make some lives precarious and others seem more secure. So the challenge, the political and ethical challenge, is to build a livable world for everyone by questioning what constitutes a life worthy of recognition and protection. And so we need to move the focus beyond individual survival to one of shared social conditions. And this is not just true for queer trans communities or caste marginalized communities, by the way. As was mentioned in my introduction, I'm an animal behaviorist by profession and trade. I still practice. And for those of us who work with animals, especially veterinarians, we are at a very high risk of suicide. Data where it is available in the US, Australia, and UK mainly, shows that veterinarians are at the highest risk in terms of occupation, sharing risk levels with police, firemen, and other first responders. Again, personally, one of the tallest leaders in my field, an international icon, someone who changed veterinary, I guess, practice, a pioneer in coercion-free techniques, Dr. Sophia Yin, was lost to us by suicide. And again, as a community, I think this led to so much suffering, angst, and mourning for us. There was no one single cause, such as a mental illness. But what there was social pressures faced by those of us who work in this field, from others, from people who we love, from neighbors, from clients. And this came, I think, a couple of years after I had conducted an action research in the Indian context for those of us who work in animal-related professions. And the findings matched what we know from abroad. The work isn't seen as respectable enough. And in the Indian context, this is heightened. Harassment faced from family, from clients, others, etc. And these are the same pressures that affected a 19-year-old fellow professional and friend of mine. He was 19 and he ended his life due to conflict with family and joint family over this choice of career. This is also why MHI chose to conceptualize and run a suicide prevention action training for community-based organizations who work on any issue. And just some examples are diamond worker unions, trade unions, those who work on livelihood support, those who work with survivors of violence. So the idea is to embed suicide prevention in all of these, and that's why we run this particular type of program as well. When I started speaking, I spoke about portrayals in the media. And I started speaking with it because I think it's important. And we should remember that public narratives shape how how society understands suicide. Sensationalized reporting, simplistic reporting, sure, but that type of reporting also obstructs structural issues. So, through partnerships with press organizations and journalism networks, we've worked to build more ethical, intersectional storytelling so that the media itself becomes part of the prevention, not part of the harm. And just this year, we've run multiple workshops with reporters, editors, photographers, and translators from across India who listened to, yes, some mental health professionals, but also non-profits, practitioners, activists, and community organizations such as Thar Mahila Sansthan or TYCL or queer trans collectives on a range of topics such as visual and ethical storytelling, care, consent, dignity in reporting, but also structural causes of distress. And the reason that I mention the media again is because I want to center the idea of lived experience. This is especially important for funders. If you are funding, you must fund research and communities to work together to produce evidence. This allows complexity, context, relationality to surface far more than any top-down, purely clinical framework could. Simply because whether it's for media or whether it's for research, suicide prevention is not just happening in clinics or crisis centers. It's happening in kitchens, in hostel rooms, in neighborhoods, classrooms, fields, in community halls. This also means funding marginalized researchers or community members to present and disseminate their work. And there are avenues for funders to do this. For example, we supported various partner organizations to travel to IASP and funded a regional IASP convening for knowledge sharing. I'm going to wind up by saying, I think for me at least, the vision requires building safe, compassionate ecosystems. When we talk about suicide through a structural lens, we're also talking about the need to build ecosystems of care, right? And ecosystems of care cannot be built by one sector. Yes, we need the mental health professionals, but we also need linkages to stable housing, linkages to food security, safety from violence, accessing services without fear and discrimination, the upholding of rights, not only in theory, but in everyday practice. Because the aim is not just to rescue people from crisis. The aim should be to reduce the likelihood of crisis in the first place. And for that, we need collective action. So now I'm going to give action points, especially for funders, because that's where I'm from. Number one, provide long-term flexible support, fund relational community-based work, back cross-sector collaborations, and really value and elevate lived experience leadership. For the practitioners in the room, go beyond diagnosis, integrate or link to legal, social, and community supports. Think about it as working in teams rather than in disciplines. For policymakers, integrate mental health into housing, labor, education, and welfare policies, and vice versa. Address the documentation barriers that many, many communities face. The oppressions are necessarily linked, by the way, because those who are disabled, those who are queer trans, and those who are Dalit, Bahujan, Adivasi, when they engage with the system, so there's a big documentation gap, and then you're denied services or denied welfare because of this documentation gap. And you'll see it in climate emergency shelters, where you don't get access or you don't get the welfare benefit. And this is why for policymakers, just as the Supreme Court did, you need to create accountability mechanisms for discrimination and exclusion. I think for NGOs and civil society, build coalitions, share knowledge. Part of all of our job is to hold systems accountable and to center those who are most affected. I think suicide prevention can succeed when we don't work in silos, but when we work in concert, because we need to transform the conditions that give rise to distress. We need to shift systems, not just focus on shifting behaviors. It is at the end about dignity, equity, and justice. And especially for those of us with resources such as me, resources, influence, and institutional power, is to learn from communities across India who do this actually on the daily and invent very creative, compassionate, contextually rooted responses to distress. Because in the lack of that support, they've been building safety in ways that our formal systems are yet to imagine. So, as those of us who are interested in suicide prevention, we should not be suffering from a crisis of imagination. And if we focus only on the dominant ways to respond to suicide, then it's a crisis of imagination. It's a shared social responsibility. It belongs to all of us. And when we take it up together, we know that it is, in the end, about building a world where dignity is non-negotiable, where belonging is possible, and where systems don't produce despair. And in that sense, this is work that belongs to all of us. It requires, I think, attention from all of us. And I'm going to end again, since I'm implicated in this as a funder. It is solely our responsibility and those with more power in the room to connect these dots and take it forward, because we have more resources than everyone else in the room. Thank you.
Thank you so much, Raj, for this beautiful, grounding, and very, very enriching keynote. If any one of you has any questions, any reflections to share, or anything to ask, please, you're welcome to do so. Yes, please. Can we have a mic here?
I can do without a mic.
Okay.
Hi, Raj. It's an honor and a pleasure to listen to you. I flew in from Dubai for this conference. I'm a survivor of suicide loss myself, and the engagement of the lived experience as a survivor, I'm very happy. So I was just expressing my gratitude. Can you hear me now? So I was just expressing my gratitude. It's been an honor and a privilege to listen to Raj. I flew in from Dubai, and I think the return on investment has just come my way. I am a survivor of suicide loss myself, and the emphasis that you have very uniformly projected, that how critical and important and imperative it is to include the lived experience aspect with research. So I want to volunteer myself. Why? There are enough survivors of suicide loss volunteers. Manjeet had mentioned there are some programs going on already in the country. The point is, I became a survivor 25 years ago. So for me, my lived experience is 25 years young. And in these 25 years, I have two children that were also survivors of suicide loss. They are now grown adults. We mention about in psychiatry and psychology, we talk about childhood trauma. Now, these young adults are part and parcel of the society today. They are trying to stand with the peer group, but what they have undergone and what they have had to navigate is slightly different from the peer group. And that voice is something that is in a vacuum. Because I don't expect my children, or nor have I ever gone out and made this as my opening statement that I'm a survivor of suicide loss. Because they'll say, what is that? What is that? But then I say to myself, that is me. So that gap. And then not just the queer community. You know, I will not mention the family that I got into, and we are the leftovers, right? Literally the leftovers on the plate. They belong to a very high society demography. So where is the space for people like us to look for justice, look for equity? So there are very subtle nuances, you know, in the conversation that really need to be heard. If I don't know when action will happen, I don't care. So thank you, and I need a copy of your keynote address, please. I need it desperately. Thank you.
Thank you so much. Anyone else?
Yeah. Good morning, everyone. My name is Meenakshi Nagwekar, and I represent my organization, Sisters Living Works. We are an organization in Mumbai that works very closely with the same cause. And just to mention that, just to people to know that we are the one organization that works on suicide prevention. And we have been running various programs, which could be awareness programs, support groups that we run. We have very specifically, we have certain community-based programs that we run. We have been doing counseling sessions with certain communities also. So please do reach out to us in Mumbai, whoever is from Mumbai. Thank you.
Thank you. Thank you so much. May I request, thanks once again, Raj, for such enriching keynote. I would request Pranita to please felicitate Raj. Thank you, Raj. Thanks a lot.